Postpartum assessment, I would begin by reviewing the patient's history, including her prenatal care, her labor and delivery care, her postpartum records thus far, any history of opioid use or abuse or withdrawal, her current medications, her most recent vital signs, any recent I&Os. I would check the patient care plan, gather my supplies outside of the room, wash my hands as I come into the room, and introduce myself to the patient. Hi, my name is Nick. I'll be your nurse today. I would then ID the patient using two forms of ID, full name and date of birth, and provide privacy for the patient, closing the curtain and/or door. From here, I'd simply explain to the patient that we're going to go through a head-to-toe postpartum assessment. I would see if the patient has any questions as far as what's going to take place, and tell the patient to feel free to ask any questions throughout the assessment if any come up, and also let me know if she experiences any pain throughout the assessment as well. At this point, I would also ask the patient if she's experienced any pain currently. She advised she is not. I would raise the bed. I would initially, by just conversating with the patient, take note of her general appearance, her affect, her positioning, her level of arousal. The level of arousal and positioning can sometimes hint towards pain that the patient is in, although she may not be admitting to it at this point for whatever reason. I would take note that the baby is rooming with the patient, and the patient also has family by the bedside. I would move on and assess the patient's vital signs, including blood pressure, pulse, temperature, respiration rate, and again ask the patient if she's in any pain throughout the entire body at this time. Again, she advised she is not, and all vital signs are within the defined limits. So moving on, I would then assess the patient neurologically, asking her if she's had any recent headaches since giving birth, any changes in vision, any epigastric pain. The patient advised that she has had no changes in her vision, no headaches experienced, and she was unsure what the epigastric pain was, so I simply explained to her that this is upper abdominal pain, usually found right below the ribs, that's sometimes experienced with digestive issues or just simply an upset stomach. Patient then advised that she has had no epigastric pain, and I simply let her know if she does, obviously just let us know. At this point, I would auscultate the lung and heart sounds of the patient. And I'm hearing no abnormalities in the lungs, no abnormalities in the heart sounds. I would then check the capillary refill of the patient, and that's returning within the defined limits there within about 2 seconds, so no issues there. I'd move on and ask the patient if she is breastfeeding. She advised that she is and plans to throughout at least the first 6 months. And due to the fact that she is breastfeeding, I would let the patient know that I am going to assess her breasts and her nipples. This is just to ensure that the breastfeeding is taking place okay at this time and can continue to take place with no issues. Upon assessing the breasts, I would only uncover what I need to here on the patient, preserving her dignity. I would palpate the breasts. They are soft, and the patient advised that she has no soreness, no tenderness, and no pain in the breasts at this point or while breastfeeding. I would also assess the nipples. And on the nipples here, I see that they are intact. They are not flat, not inverted. I see no redness and no cracking. At this point, due to the fact that the patient did advise that she is going to continue breastfeeding, I would educate the patient on some abnormalities that may be seen later in breastfeeding, that she would need to notify us about if she does experience. These would include the nipples being painful or any swelling within the nipples. These could be signs of infection. And any cracking in the nipples could be due to inappropriate positioning of the infant, of the baby, while breastfeeding, or too vigorous of a sucking by the baby while they are breastfeeding. From here, I would move on to assess the uterus. I would lower the head of the bed. I'll just lower the baby or the mother here since I can't do that. Get her in a better position there for assessment. I would palpate the uterus, one hand above the symphysis pubis and the other hand feeling for the fundus. I would locate that, palpate it. It is firm and it is at the top of the, right at the level of the navel, which is appropriate for this point postpartum. So again, no abnormalities there. As I am down there, I would also palpate for a distended bladder. There's nothing that I can feel here as the bladder is not distended, which is a good sign. And I would ask the patient when she last voided urine. She did advise that that was about 20 minutes ago, which is obvious due to the fact that I do not feel any distension of the abdomen there. Due to the fact that the patient advised that she did urinate about 20 minutes ago, I would ask her if she had first any trouble getting to the bathroom, see if the anesthesia has worn off. She advised she experienced no problems getting to the bathroom, no dizziness. But I would take some time here to educate her on orthostatic hypotension, which is very common after pregnancy, and just advise her to, when she's changing positions from laying to sitting, sitting to standing, just to do that a little slower than she usually does, just to alleviate any chances of that orthostatic hypotension taking place, which could cause some dizziness and obviously just not safe for the patient. So just want to keep her safety first. Also with the urination, I would ask her if there was any trouble or if she experienced or if she noticed any foul smell of the urine. She advised that she did not. So again, no abnormalities there, and nothing to worry about with the urination. From here, I'd move on to assessment of the patient's abdomen. I would begin by auscultating all 4 quadrants. And I am hearing active bowel sounds in all 4 quadrants, which is a good sign. I would then visually, as I'm auscultating, I would also visually assess the abdomen for any redness, ecchymosis, edema, any drainage, and just make sure the abs are well approximated, which they are. So again, no issues there. I would also ask the patient about her last bowel movement. She did advise that the last bowel movement she remembers was the day before she gave birth. At this point, I would take some time to educate the patient that constipation is normal after giving birth for the first few days. And at this point, nothing, no issues to worry about, especially due to the fact that I was hearing active bowel sounds within all 4 quadrants of the abdomen, and just advise her that this is a good sign that the bowel movement and her regularity in bowel movement should continue, or should start here again soon. But to obviously keep an eye on it herself and let us know within the next couple days if she continues to be unable to have a bowel movement. And obviously we'll continue to assess that as well. From here, I will move on to a assessment of the patient's genitalia. Again, only exposing what I need to when I need to, pulling back her blanket here. And I would check her pad and assess it for the lochia At this point, I am seeing a small amount of lochia, and it is rubra, which is dark red. And at this point, postpartum, that's exactly what we want to see. I just want to let the patient know that this is normal at this time, and also educate her on if she does see any abnormalities or significant changes in the amount of lochia, the color of the lochia, or even the odor of the lochia, to go ahead and let us know, and we can take note of that to see what the issues may be. Could be possible signs of hemorrhaging. At this time, I would turn the patient on her side and assess for any pooling of blood, which could be signs of hemorrhaging. I would ensure that the perineal area is clean, and check her episiotomy as well, assessing for any signs of infection, making sure that it is healing appropriately, and ask the patient if she's having any pain in the epigastric area at this time. Just making sure everything's healing okay there. She advised no pain in the, not in the epigastric area, in the episiotomy that she had giving birth. She did advise no pain there. I'll roll her back. Actually, once she is on her side there, I will also gently lift the upper buttocks and assess for any swelling, any hematoma, any hemorrhoids, and again, see if there's any pain. And then also ask the patient if she's been able to cleanse that perineal area appropriately, and see if she has the appropriate supplies to do so as well. She said she's had no issues, no pain, and she has plenty of supplies at home to keep that area nice and clean. I do a little education here as well, as far as just educating the patient on the reasoning behind the, keeping that perineal area clean, especially with her episiotomy and any signs of infection or anything there. I would take off my gloves, throw these away after the perineal examination and genitalia examination, wash my hands, put on new gloves. And at this point, I would move on to assessing the lower extremities of the patient. Pull the blanket back this way. And again, just ensuring that the patient, she did advise she got up about 20 minutes ago to go to the restroom. I would ensure that she had no trouble doing so. See if she had any tingling, any numbness within her lower extremities. She advised she has not. At this point, I would ask the patient to put both feet flat on the bed and raise her bottom. Again, this is just ensuring that she has proper movement, no numbness, no tingling within the lower extremities here, and make sure that she could move all of her extremities well at this time, including her legs and her arms. I see no abnormalities at this time there. Again, I would remind the patient about the orthostatic hypotension that can take place postpartum at this time. I would also check both legs for DVTs, any redness, any edema, and also assess her pulses, including her posterior tibial and dorsal pedis pulse. I would check her deep tendon reflexes, and I'm getting a +2 on both of those, which is shows no signs of abnormalities. That is a +2 normal. Average deep tendon reflex there. If there was any abnormalities here, I would simply educate the patient on the fact that this could be signs of preeclampsia. From here, I'll move on and assess the IV side of the patient, and I would assess the Foley catheter as well if she had one in. She does not. I see no abnormalities in the IV side of the patient. Throughout all the interaction with the patient, throughout my assessment, I would be taking note of her emotions, how she seems to be bonding with the baby, her interest in her self-care and the baby care. The fact that she's making eye contact with the baby, that she doesn't seem to be having any postpartum blues at this point, but I could educate her a little on that as well. Just advising her that the postpartum blues are normal postpartum, and if she does notice those getting any worse, or if she does need to talk to anybody about that, just simply let us know. I would educate the patient also on getting rest once she is home and here in the hospital, and just let her know that it's always smart to sleep when the baby's sleeping, and to always allow others to help out in any way that they can, including making meals, doing any household chores, anything that can alleviate some stress and or give the mother some free time or some time to rest. I'd make sure she's eating and drinking well. She advised that she's had no problems there. And just take note of her family support as well. Like I said, she does have family by the bedside, and they seem to be very supportive at this time. At the end of the assessment here, I would simply ask the patient if she's in any pain or if she experienced any pain throughout the assessment. Again, she advised that she has no pain currently and experienced no pain throughout the assessment there. And I just remind her just to let us know, not feel uncomfortable doing so or embarrassed if she, seems to experience any pain. Even if she doesn't want to take medications for the pain, there is other interventions that we could explore for that. From here, I'd return the bed to the lowest position, make sure the patient is comfortable, make sure her call light is within reach, and assess for any further needs, see if the patient needs anything, water, food. At this time, I'd simply update her on the plan from here through discharge, and let her know I'll be back around in 30 minutes or so, just to get an update as far as how she's feeling, and if she does need anything in the meantime, she has her call button there. I would dispose of my PPE, clean any equipment that I used on my assessment with the patient that is not disposable. I would wash my hands and document everything and anything that went on during the assessment to ensure that proper care can continue for the patient. Thank you.